All right, so a very good evening, everyone. So, am I audible to everyone? Just give me a thumbs up or like yes. Am I audible to everyone? Right, very good evening, Nagadikshita. So, let us start with the today's session. Right, so a very important clinical based question. We have a 35-year-old female presents to the OPD. So, first of all, let me just give you a small introduction. So in order to see that you should not face any difficulties in your upcoming FMGE exam, we at Arise Medical Academy are conducting everyday sessions on clinical based questions and as well as image based questions. So this session will be for 1 hour and please utilize these clinical based sessions. And along with attending your theory classes, these clinical based sessions also are very, very important. These clinical based sessions are the one which will give you that 150th mark from 149 to 150th mark is given by these clinical based questions, right? So as all of you know, 150 is equal to 300 in FMG and 149 is equal to 0 in FMG. So we at Arise Medical Academy are giving you that 150th mark which will be equal to your 300th mark. Okay, so please attend these sessions and try to utilize this, and you should not regret after your December 4th exam that we did not attend the clinical based sessions. Okay, so please attend all these sessions which are very, very important, and I'm discussing the clinical based questions, and I'm also trying to explain you how to analyze the question. All right, okay, so yes, yeah, Sai Tarni, Ashwini, Priya, good evening. Now we have a 35-year-old female presents to the OPD with complaints of fatigue and the weakness. She has had decreased appetite, weight loss, and severe lightheadedness upon standing. Vital signs show a heart rate of 88 beats per minute, respiratory rate 18 breaths per minute, temperature of 37.2 degrees centigrade. The examination is remarkable for pigmentation of the oral mucosa. Right, remarkable for the pigmentation around the oral mucosa. There is proximal muscle weakness of the lower extremities and hyperpigmentation of the palmar creases, knuckles, and as well as knees. What is the most likely diagnosis in this patient? Adrenal insufficiency, depression, anorexia with surreptitious diuretic use, hypothyroidism. Yes. Who will be the first person to answer this question? Any one of you, please. Very good, Chandia. So Chandia has already answered the question, and very good evening, Chandia. So the answer is the adrenal insufficiency. Right. So now the point is why it is adrenal insufficiency. What are the points in favor of the adrenal insufficiency? Let me tell you. First, clinical manifestations. There is weight loss. So in patients with adrenal insufficiency, let me tell you, they'll have the weight loss. That is first important thing. And apart from that, you take the pigmentation. Pigmentation is the one which is very, very important thing to tell that it is an adrenal insufficiency. Right? And that too, the pigmentation in the mucocutaneous areas, that is the oral mucosa, and as well as the pigmentation over the knuckles, pigmentation over the palmar creases. They are classically seen in patients with the Addison's disease, right? Now, can anyone give me a differential diagnosis for knuckle pigmentation? Yes, differential diagnosis for knuckle pigmentation. Any one of you, please? Right, let me tell you. So differential diagnosis for the knuckle pigmentation is that you will have in vitamin B12 deficiency. So that is megaloblastic anemia due to vitamin B12 deficiency. You will have this knuckle pigmentation. Okay. Remember that very, very important point. Now, in case of the other options like depression, anorexia with surreptitious diuretic use, in hypothyroidism, you will not have all these manifestations. In case of hypothyroidism, in fact, what the individual will have is weight gain. They will not have weight loss, they will have weight gain. So your hypothyroidism is completely ruled out, right? And even you take in case of the depression. So it all depends. Again, in depression, if the individual does not eat properly, they'll have weight loss, right? And this is a question because there is weight loss, pigmentation, and lightheadedness upon standing. All these are the pointers suggestive of adrenal insufficiency. Now, can anyone tell me what is this sign lightheadedness upon standing? Yes, anyone of you, please. What is that lightheadedness upon standing? What does that sign or symptom tells you? Yes, anyone of you, please. No. It is not the point in favor of your weakness. So lightheadedness upon standing, it tells you postural hypotension. Very good, Sai Ratan. Very good, Sandeep Chandra. So it is nothing but postural hypotension, right? Postural drop in the blood pressure of the individual. So that postural hypotension is the one which is seen in patients with adrenal insufficiency. Now, why do you have that postural hypotension? That postural hypotension is mainly because of decrease in the aldosterone levels, right? And as well as decrease in the cortisol levels. So what do you mean by the word Addison's? Addison's is nothing but your adrenocortical insufficiency. Decrease in corticosteroids, decrease in mineralocorticoids, and as well as decrease in your weak sex hormones. Okay. So lightheadedness upon standing is nothing but your postural hypotension. So this is a classical case of the adrenal insufficiency, which is nothing but Addison's disease, right? Now, can anyone tell me what is the most common cause of adrenal insufficiency in India? What is the most common cause of adrenal insufficiency in India? Yes, who will be the first person to answer this? Most common cause of adrenal insufficiency in India. Right. So let me tell you, the most common cause of adrenal insufficiency in India is tuberculosis. Right. Very good, Shankar Deepu. So in India, the most common cause is tuberculosis. But whereas if the question is asked in Western countries, what is the most common cause? In Western countries, the most common cause is autoimmune disease. Right? In Western countries, the most common cause is autoimmune destruction of the adrenal gland, right? So that is about this clinical question on adrenal insufficiency. Now, can anyone tell me, last point, can anyone tell me what is the investigation of choice, this investigation of choice for this adrenal insufficiency? Anyone of you, please? So remember, the investigation of choice in case of adrenal insufficiency is co-syntopin test. Right? It is co-syntopin test. So co-syntopin test is the investigation of choice in case of adrenal insufficiency, right? Now, coming to the treatment. So you should also know at the same time, what is the drug of choice for the adrenal insufficiency or the Addison's disease? The drug of choice for the Addison's disease, it is your hydrocortisone. Right? Drug of choice is hydrocortisone. Okay. So, and Addison's disease is what? That is your primary adrenal insufficiency. Primary adrenal insufficiency is nothing but your Addison's disease. And the drug of choice for your Addison's is your hydrocortisone. All right. So these are some of the very important points related to your Addison's and as well as its clinical based question. Next. Yeah, this is another very interesting question, and let me see how many of you will answer. A 45-year-old man presents with diminished vision in the right eye, and on examination, Marcus Gunn pupil is noted. MRI was performed. What is the diagnosis? Neuromyelitis optica, rhabdomyosarcoma, retinoblastoma, optic nerve glioma. Yes, any one of you? A 45-year-old man with diminished vision in the right eye. See, in MRI, it will be reversed. So this is your right and this is your left. Right. So yes, so we got the correct answer from Nagadikshita, Tenso, and whoever has answered D. The answer is the optic nerve glioma. So in case of the optic nerve glioma, right, you see this is your glioma. I'll just mark it for you. This is your optic nerve glioma. And in case of this optic nerve glioma, you will have the Marcus Gunn pupil that is being noted. And even the MRI is also showing the presence of the optic nerve glioma, right? Next. Now, what about the other options? How do you rule out the other options? Let me take up. Now, in the image, what is that you are able to make out? There is presence of large retrobulbar lesion. This is your large retrobulbar lesion. That is what is suggestive of your optic nerve glioma. Whereas left side, you see, this is your normal optic nerve. Right, this is your normal optic nerve. But on the right side, if you see, there is presence of large retrobulbar lesion. Okay, so that is one important point. Next. Now, the other thing is rhabdomyosarcoma. Why not rhabdomyosarcoma? Let me tell you, rhabdomyosarcoma is the one where the presentation will be in the first decade of life. Right, the presentation will be in the first decade of life. Next, in rhabdomyosarcoma, there will be presence of bilateral proptosis. Right, in rhabdomyosarcoma, you will have the presence of bilateral proptosis. So, what is the age of our patient? 45-year-old man. So that is the reason why your rhabdomyosarcoma is ruled out. Now, you take the other options. The other options like neuromyelitis optica. See, neuromyelitis optica, what will be the presentation is, these individuals, they will have involvement of the optic nerve where optic neuritis occurs. Right, where there will be optic neuritis. And the other important point is that, right, the other important point is they will have ascending paralysis. Right, they will have ascending paralysis. Okay, so these are the very important features of your neuromyelitis optica. Right, next. Now, so this is how you need to rule out the other options, right? But the important point which is present here to suggest optic nerve glioma is, along with the MRI, presence of the Marcus Gunn pupil. Marcus Gunn pupil, it is also being given by the other name called as RAPD. So what do you understand by the word RAPD? That is relative apparent pupillary defect. Relative apparent pupillary defect or relative afferent pupillary defect. Right? That is what is called as the Marcus Gunn pupil, which is seen in case of the optic nerve glioma. Right? Next. Yes. So now one question related to your COVID-19. Now this is the era of COVID-19. Right? This is the era of COVID-19. Now, definitely one question you can expect, one or two questions you can expect on the COVID-19, right? So now you are the junior resident, right? As a junior resident, you are managing a patient of COVID-19. When will you stop the treatment in COVID-19 patient? 2 consecutive negative PCRs report at least 48 hours apart with clinical radiological improvement. 2 consecutive negative PCRs at least 24 hours apart with clinical radiological improvement. 3 consecutive negative PCR reports at least 48 hours apart with clinical radiological improvement. 3 consecutive negative PCR reports at least 24 hours apart with clinico-radiological improvement. Yeah, so this is a very, very important question related to your COVID-19. Yes, Ratan, when do you want to stop? So 2 consecutive negative PCRs, at least 48 hours you want to wait, okay. Right, so I got the correct answer only from Sai Taruni, and now Gangula Akanksha has also answered it. Very good, Sai Taruni and Gangula Akanksha. So the answer is second option. So I require 2 consecutive negative PCR reports, at least 24 hours apart, not 48 hours apart, 24 hours apart with clinico-radiological improvement. Then only I can stop, right? Then only I can stop the treatment of the COVID-19. Okay, so this is one of the very, very important question, very practical question as well. So when will you stop the treatment of COVID-19? 2 consecutive negative PCR reports at least 24 hours apart with clinico-radiological improvement. So that is what is related to your COVID-19. Right, now the next question is an image-based question. Next question is an image-based question. Yeah, so I have a HIV positive truck driver develop seizures, and CT scan of the head is performed and it is shown to you. This is the CT scan of the head. What is the diagnosis? Neurocysticercosis, cerebral toxoplasmosis, primary CNS lymphoma, tubercular meningitis. Yes. So you are very much aware that in patients with HIV, they are more prone for the opportunistic infections. So CD4 count once it is reduced, then there is high chance of development of the opportunistic infections in these individuals. So similarly, even this patient is also developed some opportunistic infections and has developed seizures as well. And the CT scan is shown to you. What do you think is the correct answer? Right. So this is one of the very, very important question, and I can see very few people answering the questions correctly. Right. So the answer is very good. So whoever has answered cerebral toxoplasmosis, that is a correct statement, right? Whoever has answered cerebral toxoplasmosis is correct. Now, I will ask you a question. Why not neurocysticercosis? Yes. Please tell me, why not neurocysticercosis? Any one of you? So in neurocysticercosis, what is that you will have is, yes, who will be the first person to tell me why not neurocysticercosis? Very good. So Gopalakrishnan has answered it. Very good, Gopalakrishnan. So in case of neurocysticercosis, you will have multiple intracranial space occupying lesions. Right, you will have multiple intracranial space occupying lesion. But if you see this image here, only one intracranial space occupying lesion is there, which is going against your neurocysticercosis. Which is going against your neurocysticercosis. So that is the reason why the answer is not neurocysticercosis. That is completely ruled out. Now you take the tubercular meningitis. I will come to the primary CNS lymphoma later. Right. So I'll come to the primary CNS lymphoma later. But tubercular meningitis, yeah, tell me, why not tubercular meningitis? Right, why not tubercular meningitis? So if the question is asked like why not the tubercular meningitis, but as such, if you take the tuberculosis is one of the very common opportunistic infections what you will have in patients with the HIV, right? But in this scenario, it is not your tubercular meningitis. Now, why is that? Let me explain. So in case of tubercular meningitis, like for example, if the individual has to develop seizures, there should be also involvement of the brain parenchyma, right? There should be also involvement of the brain parenchyma. Only meningitis will not cause seizures. Along with meningitis, there should be development of meningoencephalitis, right? There should be development of meningoencephalitis. That means involvement of meninges and as well as the encephalon, that is brain parenchyma. Both have to be involved. Then only the individual will develop the seizures. Now, in case of tubercular meningitis, what is that you will see in the CT scan is you will be able to make out the presence of the hydrocephalus, right? You should be able to make out the presence of the hydrocephalus. So hydrocephalus is not there in this patient. Now, how can you make out, right? How will you make out that there is presence of hydrocephalus in your CT scan? Yes, anyone of you? How will you diagnose that there is presence of hydrocephalus in the CT scan? Now, I am telling that this patient is not having hydrocephalus, so that is why it is less likely to think of tubercular meningitis, what I am telling. So how can you tell that there is no hydrocephalus in this patient? Very good, Ceci Murugan. So in hydrocephalus, the ventricles will be wide. Right? So you have a completely wide ventricles in case of the hydrocephalus, and that is, yeah. So you are not seeing enlarged ventricles, right? You are having the normal ventricular size. So that itself will rule out your tubercular meningitis. Okay? Right. Now, what about the other options? Like, for example, you take primary CNS lymphoma. In case of primary CNS lymphoma, how will you differentiate this from toxoplasmosis is? This cerebral toxoplasmosis, you can have multiple lesions. You can have, but actually in your CT scan, what has been shown is the solitary lesion. But in cerebral toxoplasmosis, you can have multiple lesions. And CNS lymphoma, it is always single lesion, right? It is always single lesion. And you take the enhancement. You have ring or nodular enhancement, whereas in case of CNS lymphoma, there will be a very solid enhancement, right? I'll show you both, okay? Now, you see this, the enhancement, whatever is there surrounding the lesion, it is a ring enhancing lesion, or, right, or we call it as nodular enhancement. Whereas in case of CNS lymphoma, I'll just show you the image of the CNS lymphoma. This is the image of the CNS lymphoma. So what is that you will have in CNS lymphoma? You will have a very solid enhancement. Right, you will have a solid enhancement here in case of the CNS lymphoma, all right? So which is not there in case of, just 1 minute. Right, so which is not there in case of the toxoplasmosis. So ring enhancement lesion or nodular lesion in case of toxoplasmosis, whereas solid enhancement in case of CNS lymphoma. In toxoplasmosis, there can be solitary lesion or multiple lesions, but in CNS lymphoma, it should be always a solitary lesion. So these are some of the differences between the toxoplasmosis and as well as CNS lymphoma. But let me tell you, the primary CNS lymphoma can also be seen in HIV positive patients, right? So this completes this image-based questions. So what is the take-home message? Neurocysticercosis, it is always multiple space occupying lesion. Cerebral toxoplasmosis, solitary lesion or multiple lesion, but they should have ring enhancing or nodular enhancement lesion. Primary CNS lymphoma, it is always solitary lesion, but it will be solid enhancing. And tubercular meningitis, usually they present with the hydrocephalus, where you have the ventricles being very wide. Yes. Yeah, you see this question. We have a 55-year-old woman came to the emergency department with complaints of the headache, severe headache. She also mentions that that this is the worst headache of her life. What is the most appropriate initial test for diagnosis? Cerebral angiography, computed tomography of the head with intravenous contrast, computed tomography of the head without intravenous contrast, lumbar puncture. Most appropriate initial test. Right, very good. So can anyone tell me what is the diagnosis first of all? What is the diagnosis? And before that, tell me, do you have any class at 7:30 today? Yes, do you have any class at 7:30 today? Right, so the diagnosis, very good, Ashwini Priya. It is a case of subarachnoid hemorrhage. It's a case of subarachnoid hemorrhage. So how will you diagnose your subarachnoid hemorrhage? So the diagnosis of subarachnoid hemorrhage is by CT scan without contrast material. You should not use any contrast material. Why? Why? Because in a case of subarachnoid hemorrhage, if you are using any contrast material, let me tell you, first of all, subarachnoid hemorrhage is due to either head trauma or rupture of berry aneurysms. Right, it is due to rupture of the berry aneurysms. Okay, so now whenever there is a rupture of the berry aneurysm, whenever you are trying to give a contrast, right, there is a rupture of the berry aneurysm causing subarachnoid hemorrhage, and at the same time you are giving an intravenous contrast. What will happen? That contrast material will enter into the subarachnoid space, and that will cause very severe consequences. So that is the reason why in a case of subarachnoid hemorrhage with an underlying suspicion of rupture of berry aneurysm, please don't give intravenous contrast, right? Please don't give the intravenous contrast. Okay, right. And the investigation of choice will be definitely, right, the investigation of choice will be definitely the CT scan. And what will be the treatment? Right, what will be the treatment? Like for example, if it is due to rupture of the berry aneurysm, right, if it is due to rupture of the berry aneurysm, you need to do a surgical evacuation, right? You need to do a surgical evacuation. Okay, and you should also give calcium channel blockers. Right, you should also give the calcium channel blockers. So why you should give calcium channel blockers? Mainly to prevent the vasospasm, because in case of subarachnoid hemorrhage, as a compensatory phenomenon, there will be very severe vasospasm. So in order to prevent that particular vasospasm, we give calcium channel blockers, because if you don't prevent that vasospasm, the individual may land up in stroke. Right, if you don't prevent that vasospasm, the individual may land up in stroke. Okay, right. Now, can anyone tell me what will be the lumbar puncture picture in patients with subarachnoid hemorrhage? Yes, anyone of you? What will be the lumbar puncture studies in case of subarachnoid hemorrhage? So if you do a lumbar puncture study, lumbar puncture, it will show the presence of xanthochromia, right? The presence of xanthochromia. So presence of xanthochromia is a very important lumbar puncture study in case of subarachnoid hemorrhage. So what is that xanthochromia? Presence of RBC within the CSF. Right, presence of RBC within the CSF. It gets ruptured, and whatever the hemoglobin is released, that will be converted into bilirubin, and that will give you yellowish nature to the CSF. Right, and that is what is called as xanthochromia. So which all conditions you will have this RBC in the CSF? One in case of subarachnoid hemorrhage, right? One in case of the subarachnoid hemorrhage, right? And the other one is in case of HSV, herpes simplex virus encephalitis. There also you can have the presence of RBC or xanthochromia can be there. Okay, so this is about a clinical question related to your subarachnoid hemorrhage. Okay, right. Now, so okay, because you have the surgery class at 7:30, I don't want to disturb your class, right? So with this, I will wind up the today's session. The today's session I have just kept myself for half an hour in order to see that you should not get disturbed with your surgery class parallelly. There should not be any overlap. So that is the reason why I just wind up the session for today. And tomorrow at the same time, most probably in between like 6:30 to 7:30 or 6 to 7:30, sorry, 6 o'clock to 7 o'clock, I'll try to plan the session. And tomorrow, can you tell me like at what time you people are free? Is it like 6 to 7 you are free, or 6:30 to 7:30 you are free? Which time are you free? So if you can tell me accordingly, I try to schedule my class tomorrow, right? So with this, I'll just wind up this session. right? And please don't neglect these clinical based questions and image based questions. They are FMGE exam, right? So thank you very much and see you tomorrow again.